Okay, right, lovely. Thank you very much. Right, welcome everybody. So I'm a psychiatrist and I've been a psychiatrist for 30 years. I was just thinking about that today. 30 years is a heck of a long blooming time to be a psychiatrist. How on earth have I managed to be a psychiatrist for 30 years? I guess because I enjoyed being a psychiatrist. I didn't expect to become a psychiatrist when I started medicine. I sure as heck didn't expect to be a psychiatrist. That was pretty much the last thing I thought I would end up in. So how have I ended up in psychiatry and why do I think it's so interesting? I work in a very specialized service. I see patients with depression and bipolar disorder. That's all. You could go, well, that's pretty boring, isn't it? You're only seeing patients with two different conditions and they're similar as well, depression and bipolar disorder. How on earth can that be interesting? Well, I think it's absolutely fascinating because mood disorders, bipolar depression, influence every aspect of an individual's life. Their physical health, their relationships, their ability to be able to function in society. But everything in their life also influences their mood disorder. So when you're trying to help somebody with a mental illness like a mood disorder, you need to take into account everything else that's going on. Their physical health, their relationships, where they're living, their employment, everything about their life. So every single patient is completely and utterly individual. And that's what keeps me really excited and interested in the job that I do, because every patient I see is completely and utterly different. But there are also other things that are really exciting and interesting about mental illnesses and mood disorders in particular. And I'm going to try and get some of this across to you this evening. So I've changed the title of my talk slightly to Shock, Intrigue and Inspiration. So I'm going to start off by saying what depression is and then move on to the other three bits. So what is depression? Well, the word depression can be used in two different ways. It can be used to describe a symptom, a single symptom of feeling low or sad. We all feel low and sad from time to time. That's normal. That's just normal human emotions. But the word depression can also be used to describe a syndrome. And a syndrome is a collection of symptoms, all that come together, that occur simultaneously. And the syndrome of depression, sometimes called things like clinical depression or whatever, is somewhat different to just feeling low or sad when something not very nice happens or you're just feeling down for some particular reason. Having a depressive illness is a terrible thing. And I think this is one of the best descriptions of depression. It's a quotation that comes from an entire book, which got a cracking title of Malignant Sadness, The Anatomy of Depression. And it was written by Professor Lewis Wolpert. And Professor Wolpert is an anatomist. He's now retired, but he used to work in University College London. And I like the title because it reflects his the fact that he's an anatomist. But the other thing about his book, it's quite a nice little book, it's a really fascinating read, is that what it so graphically illustrates is that depression can happen to anybody. Lewis Wolpert is an incredibly eminent and successful doctor, anatomist, and he has experienced terrible depression. I'm not going to read through that whole quotation. I'm sure many of you have been skimming through it. But what I want to do is I want to pick out a few points from this quotation. It was the worst experience of my life. More terrible even than watching my wife die of cancer. I mean, how bad must it be? I am ashamed to admit that my depression felt worse than her death, but it is true. Blimmin' heck. I mean, that is pretty horrible, isn't it? He then goes on to say, it wasn't just feeling low, depressed in the commonly used sense of the word, the point that I've just made. He felt a number of different symptoms. He was experiencing the syndrome of depression. He felt low, but he also had other symptoms. He felt ashamed. He experienced guilt. Guilt is a common symptom of depression. He felt the future was hopeless. Feelings of hopelessness, very common. And tragically, those feelings of hopelessness can spill over into thoughts of suicide. These symptoms, and there are other ones beside them, referred to as the emotional symptoms of depression: sadness, guilt, hopelessness and suicide, and lack of interest in things you normally find interesting, and lack of the ability to experience pleasure, a core symptom of depression. But Lewis Walpott also describes other symptoms. He describes not being able to think properly, let alone work, and he remained curled up in a bed all day. But sleep, despite lying curled up in a bed all day, sleep was impossible without sleeping pills. And they only worked for a few hours. And when he woke, he felt worse. What he's describing here are some of what's sometimes referred to as the physical or biological symptoms of depression. Changes in sleep, most commonly difficulty getting off to sleep, although some people have the opposite. They sleep too much. Problems concentrating, which he clearly describes. Lack of energy, which is why he lay curled up in the bed all the time. Changes in appetite, most commonly losing your appetite. Sometimes people comfort eat and overeat. And slowed movements. Now, when people feel sad ordinarily, they feel they've got low mood, so one symptom, but they may well have one or two of other symptoms. But what we say is that somebody only has a depressive illness if they got 5 or more of these symptoms at any one time, that they last for at least 2 weeks, and they are significantly impairing the person's functioning, what Lewis Walpott was actually describing. So that's what depression is. It's a syndrome. It's a collection of different symptoms. So what's the shock? The shock about depression is what the impact of it is. This is a list of the top 10 causes of years lived with disability across the world. It's actually the developed world, to be fair. And the top one isn't cancer. It isn't heart disease. It's not dementia. It's depression. Depression is the leading cause of disability in the developed world, like the UK. More than heart disease, more than cancers, and so on. It is an incredibly common and devastating condition because it is so common and therefore having a massive impact on society. But it impacts on the individual. For example, it can impair their ability to be able to work. If we look at which conditions are most likely to lead to benefit claims, the 2 most common ones are back pain and depression. And depression is over twice as common as back pain. It is the most common cause of why somebody may be off work, particularly off work for prolonged periods of time. So it has an impact on the individual, but it has an impact on society by reducing the workforce. But it has an even more profound effect on individuals. It can influence and affect their physical as well as their mental health. So for example, it increases, if you have depression and you have cancer, it increases your chance of dying from that cancer by 39%, a big increase. If you have a serious lung condition, chronic obstructive pulmonary disease, COPD, if you have depression as well, it almost doubles the risk of you dying. These 2 conditions, cancer, lung disease, they're not the only conditions affected. And it isn't just that if you have depression as well, it increases your chance of dying. Depression also increases your chance of developing physical health problems. So depression increases your risk of chronic heart disease by 60% and then doubles your risk of dying from it. Depression increases your risk of developing diabetes by 60% and then increases your chance of dying from it. So depression doesn't just influence how you see the world around you, the relationships you have with your loved ones, your ability to work, your ability to contribute to society, but it can also increase your chance of dying. Indeed, depression is associated with an average of an 11-year reduction in lifespan. Now, there's massive variability between people in terms of the impact of the depression on their physical health. So if you've had depression or a loved one has had depression, I'm not saying they will die 11 years early, but what I am saying is that they do have an increased risk of physical health problems. And in my clinical practice, one of the things that I'm constantly emphasizing to my patients and to my colleagues is that we need to screen for and treat physical health problems in our patients with depression to try and reverse this problem. But I'm also going to give you a hopeful hint at the end of my talk as well about this very shocking, somewhat depressing statistic. So let me move on to some intrigue about depression. We might think of depression as being a psychological thing. It's something that somebody should just pull themselves together and get over it. But actually, depression has physical underpinnings. We separate out, as I've just done, mental illness from physical illness, but they're not separate things. Physical health problems have mental health consequences and symptoms associated with them. If you have heart problems, it's not surprising if you've got anxiety about them. And if you have a mental health problem, it's not uncommon. And if you understand the biology behind it, not surprising that people with mental health problems also have an increase in physical health problems. They are not different. They are not different. They're one and of the same thing. So what physical health, what are the physical underpinnings for depression? Well, there's lots of different findings. And I guess before I go any further, what I should emphasize is that all of these findings, while replicated in many studies, the effect size, the difference between somebody with depression and somebody who doesn't have the depression tends to be very small. So that none of these findings have yet proved able to be used as a diagnostic test. So we can't do any blood test or scan to be able to say this person has got depression, this person doesn't. But if we do blood tests or scans in groups of people with depression and compare them with groups of similar people but without depression, we find a lot of different abnormalities. One place to start looking is the stress system within the body and brain, or one of the stress systems, the hypothalamus pituitary adrenal axis, or HPA axis. The HPA axis is activated by stress, and your hypothalamus in your brain releases a chemical that activates the pituitary, a little gland dangling down at the underside of the brain, and that releases another chemical or hormone into the bloodstream that travels around the body in the bloodstream and activates the adrenal glands that sit on top of your kidneys. And it activates the adrenal glands to release another hormone, cortisol. Cortisol is often referred to as the stress hormone. It gets the body ready to deal with stress. Now, that system is very tightly controlled. And importantly, there is negative feedback. If you release more cortisol, that cortisol acts in the hypothalamus and pituitary to turn down the activity of the axis. So it reduces the hormone being released from the hypothalamus and reduces the hormone being released from the pituitary, which activates the adrenal to produce more cortisol. So the cortisol helps turn itself off, negative feedback. If we look in patients with depression, what we find is, on average, subtle raised levels of cortisol, and particularly an abnormality in that negative feedback. The negative feedback doesn't work as well. What controls HPA axis function and feedback? Well, genes, stress, and how much stress you are under. And also, very interestingly, early life stress. Early life stress influences the way this axis works through the rest of your life to some extent. That's very interesting because early life adversity is a risk factor for developing depression. And it is hypothesized this might be one of the mechanisms by which early life stress can lead to depression later in life. Now, one of the things that control the HPA axis is genes. So what about genes? Is there evidence of abnormal genes in depression? Well, up until a couple of years ago, I would have said, well, yes, there probably is, because if you have a first-degree relative with depression, then statistically, you are at increased risk of getting depression yourself. It's not a big increase, but you do have a statistically significantly increased risk. But we couldn't identify the genes. And it's only been in the last couple of years that we've been able to start identifying the genes associated with depression. Indeed, there seem to be a lot of them, 100 maybe more. But we've only been able to identify it by doing studies such as the one shown on the screen here that looked at between 250,000 and 500,000 people. And only by looking at lots of people and looking at all the genes across your entire genome, all of your different chromosomes, we're able to identify 100 odd that seem to be statistically different in people, in the 500,000 people with depression compared to 500,000 people who don't have depression. Why do you need so many people? Because the effect of each gene is tiny. Each gene has a very small effect, increasing your risk. And we've all got some of these genes that put us at risk of depression. If you've only got a few, you probably have to have a lot of stress to precipitate depression. Whereas if you've got a lot of these genes, you may not need to be stressed as much before you might develop depression. So depression, or the occurrence of depression, depends upon an interaction between your environment and stress within your environment and your genes. How does that work? Well, some genes influence how you respond to stress. So this is looking at cortisol, the amount of cortisol in your body released by the HPA axis when we stress healthy volunteers. And you see an increased level of cortisol, there's this curve going up. And how much it goes up depends upon individuals' genotype. So this is looking at a particular gene that comes in two forms, short and long. And if you have two versions of the short form of the gene, then you have more cortisol released when you're stressed than if you don't have two short forms. And that increased release of cortisol may be important in terms of putting you more at risk of depression. And that's shown in this slide here, which is looking at the relationship between risk of depression on the y-axis and number of stressful life events on the x-axis. The more stressful life events people suffer and experience, the higher the chances are they get depressed. Everybody knows that. Everybody would tell you that stress can lead to depression, but it doesn't lead to depression in everybody. And the risks for different people varies. If you have two forms of the long form of the particular gene I've just been talking about, people tend to be relatively resilient. The increased risk of getting depression is relatively small as you experience increasing life events. But if you have the two forms of the two short forms of the gene, the ones that are associated with more cortisol being released, you are more vulnerable, less resilient, more vulnerable to becoming depressed when stressed. So evidence for stress, stress hormones, genes being involved in depression. What if we look in the brains of patients with depression? Well, we can see lots of abnormalities, but again, subtle. And we only see these if we compare groups of patients with depression and groups of individuals who are similar but are not depressed. And we see differences in the volume of different bits in the brain. We see alterations in the way the brain is functioning. And we also see differences in the connections between different bits of the brain. That's shown in the figure there. Those yellow bits of string, are connections between different bits of the brain. And those areas, those yellow bits, are the areas where we see abnormalities in patients with depression. It's pretty widespread across the brain. But again, subtle differences, not enough to cause a big enough change in an individual to be able to scan them in a brain scanner and say, oh, you must have depression. What if we look in people's blood? Can we find any markers of depression? Well, one thing that's been looked at recently has been markers of inflammation. And there's this book, it's a book for the lay public, The Inflamed Mind, and it talks about the whole hypothesis that depression relates to inflammation within the brain. On the right-hand side is a graph, a figure, and each line represents a different study that has looked at the relationship between a particular marker of inflammation and depression. And you can see there's lots of lines, lots and lots and lots of studies. And if you add all of those studies together, what you find is clear evidence of an abnormality showing raised levels of this inflammatory marker in the bloodstream of patients with depression. But again, not enough to be used to diagnose depression. So I've mentioned the HPA axis, I've mentioned differences in genes, brain structure, brain function, inflammation, lots of different abnormalities that I've not mentioned as well. So are these all different? And does an individual have one abnormality and another individual have another abnormality? Possibly, but it's also worth bearing in mind that all of these different abnormalities all relate one to another. So activities in the HPA axis influence inflammation. Inflammation influences structure and function of the brain. Changing the function of the brain will alter the way the HPA axis works, and so on and so forth. Complicated, but intriguing. So let me just end with a bit about inspiration. What inspires me, having worked for 30 years in psychiatry, beyond simply the fact that all of my patients are all individual and different? Well, the thing that I find really inspiring is all of the new treatment options that are coming along. We are developing new talking therapies, psychotherapies, and a number have been developed over the years. We are recognizing the importance of social interventions and self-help, such as diet and the importance of good diet, such as the importance of exercise. There is actually quite good evidence that exercise can work as an antidepressant and treat depression. So we've got these social interventions, we've got psychotherapies, but we've also got other interventions, biological interventions, and those are the ones that I personally am most interested in and that I've got most experience in. It's not that I think these other ones are unimportant. I think all of these interventions are important, and I use all of the interventions for my patients, but my research has been predominantly around biological interventions. So what sort of things are we talking about? So we're talking about drugs or pharmacotherapy. We've got lots of conventional antidepressants, and the evidence is that these antidepressants work. They clearly work. There's been lots of press suggesting they don't, but they do. And there is very convincing evidence that they do. There's no question that these drugs work. But there is a problem. They don't work for everybody. About 20 to 30% of patients don't respond to first or second line antidepressants. So they try one antidepressant, they don't respond to that, they try another, and they still don't respond to that second one. We're talking about probably at least 20 to 30% of patients with depression. And it's those patients that I deal with in my clinical practice. What can we do to try and help them? And it is those patients that we are particularly interested in the development of new treatments that might work in different ways to conventional antidepressants. Two of those new types of drugs are the two that I'm going to mention just now. One of them is called ketamine, or its variant S-ketamine. Ketamine is an anesthetic. It is used by vets to anesthetize horses, so it's often known as the horse tranquilizer. But it is also used by medics in the military on the battlefield, because it is a very rapidly acting anesthetic that can be administered very easily by an injection. So ketamine, it does get used in routine surgery as well sometimes, but mainly the battlefield and emergency situations ketamine gets used for. But it's also been found that ketamine can also treat patients with depression. We give a much lower dose than is necessary to send somebody to sleep for an operation. So we give a dose where they still remain awake, and we can inject that into them. And one of the things that is really surprising with ketamine is that it leads to a rapid improvement in depression. So this graph here is showing improvement in depression. So the line coming down is improvement in depression rating scale score. The lower the score, the less depressed the people are. And this is a group of people, and some have been given placebo. So it's just a bit of salty water they've been injected with. And the white circles are when they've been injected with ketamine. And what you see is these two lines separate because the ketamine is having a bigger effect on their mood than the salty water, placebo. But the really interesting thing is that we see these lines separating at 110 minutes. So in other words, just short of 2 hours. By 230 minutes, so in other words, just short of 4 hours, we see a clear separation. End of day one, big separation. This is very intriguing because conventional antidepressants, generally speaking, we don't see significant differences from placebo until a patient has been taking them for 2 to 4 weeks, not 2 to 4 hours. So this is fascinating because this suggests we might be able to treat people's depression much more rapidly. The problem, though, with ketamine is that the effect doesn't last. So after a single dose, you can see the effect gradually wearing off over the course of a week. How do we deal with that? Well, we can give them another injection of ketamine. Okay, but that means we've got to keep getting people to come in, give them an injection of ketamine, and we've got to monitor them very closely because bear in mind, this is an anesthetic. We want to make sure they don't come to any trouble with this. So we have an anaesthetist do this, keep them under close observation. It's a bit of a palaver and expensive to do. So a new version of ketamine is being developed, S-ketamine, and that's shown in the picture on the right-hand side because it comes in an inhaler. And we can squirt this up somebody's nose, and then you get a similar effect that also occurs very rapidly. It still wears off after a few days, so it does mean they have to have repeated administration of that. And we are still learning what we do about giving people S-ketamine over long periods of time. But it is an effective treatment for depression that works very rapidly. And also, very interestingly, it significantly reduces suicidal thoughts independent of improvement in mood. And in that regard, it's pretty unique. So we need to explore how this works and how it treats suicidal risk as well as low mood, and learn how we can utilize this better. So it can be used clinically now, but we need to learn more about it so we can use it better in the future. This is the second drug that I want to mention. This isn't yet available for clinical use. This is a group of drugs called psychedelics. These are drugs that give you a psychedelic experience or an hallucinogenic trip. You basically see and hear things. The drug in particular, it's called psilocybin, and that is the active ingredient of magic mushrooms. It has been used for centuries, if not millennia, by people in religious practice and also potentially medicinally. A year or two ago in London, a group of psychiatrists tried giving psilocybin to individuals with depression. Just remember back to the ketamine and esketamine. You have to keep giving that to keep getting an effect on people's depression. But in this psilocybin study, what they did was they gave a single dose of the psilocybin. The individuals had a psychedelic trip for a few hours. That was done in a very carefully controlled environment with therapists supporting the patient in hospital while that happened. But their mood improved, and that improvement in mood, despite them only having one dose of the drug, lasted for over 3 months. This initial study was very small in a tiny number of patients. The group in London have recently done a comparison comparing psilocybin with a conventional antidepressant, and that was on the BBC. And there was a whole program about it on the BBC a couple of months ago. And I've been involved in the largest study of psilocybin in the world, where the study's been run across about 20 different sites across the world, and we've treated 230 patients with psilocybin. We haven't got the results from that yet, but we will be looking at whether we can confirm this positive effect of psilocybin and then go on to do some further research before we can use this in the clinic. A fascinating and very different type of drug, because people have a psychedelic experience, not for everybody. There's a lot of people who say, no way would they want to go through that. But for people who are prepared to try that, not all of them get a response, but some of them seem to get a response that can last for months. So those are drugs. But there's another area of biological treatments that is growing, and that is what's referred to as neurostimulation. The original form of neurostimulation was ECT, or electroconvulsive therapy, where we pass an electric current through somebody's brain, and that causes a seizure. And we have good evidence that that is effective in treating depression. Not only do we have evidence that it's effective, it has got the biggest effect of any treatment we have. Psychotherapy, medication, everything. ECT, the most effective treatment. But it is associated with downsides. You have to give somebody an anesthetic when you give them this electric shock to reduce the trauma of actually having it. So you're asleep when you have the shock. We also give them a muscle relaxant so that the seizure doesn't cause a violent seizure. You actually just give them enough muscle relaxant so you just see a bit of twitching of their thumb or big toe. That's all you're looking for when you give them ECT. But ECT can also, beside the risks of giving people an anesthetic, you have, or ECT can cause problems with memory after people have had a series of ECT. So we were interested in finding alternative forms of neurostimulation. And one of the most promising is transcranial magnetic stimulation, or TMS. TMS can be administered to people while they're awake, as shown in the picture on the left-hand side. What it does is the electric current is passed through coils that generate a magnetic field. It's an electromagnet. And that magnetic field can cross the skull into the brain. It doesn't cause a seizure, and it is generally painless. I say generally because what it can do is it can cause contraction of muscles in your scalp. So that can be a little bit uncomfortable. And we give lots of pulses of magnetic pulses, which causes lots of contractions of the scalp muscles. So some people can end up with a bit of a tension headache after they've had a treatment with it, but it's easily treatable with paracetamol, and most people don't even need that. So it's generally speaking an extremely well tolerated treatment. People come in, they're awake during the treatment, and they can go home and they can drive a car straight away. They can drive their car home. Where if you have ECT, you really shouldn't be driving for 24 hours afterwards because you've had a general anesthetic. TMS has been very well studied. Again, I've got one of these graphs that look at combining data from lots of different studies. So each line represents a different study. And when you combine all of those studies together, you show a clear effect of TMS in treating depression. This is available clinically, but we're still learning a lot about how to give it in the most effective way. There's lots of variables. Where exactly do you place the coil? How many pulses do you give? How strong should the pulses be? Should it be really focused on a small area of the scalp rather than a broader area? And how do we identify where that area is? And we're currently running a large study comparing two different forms of TMS, trying to find the most effective and the one that gives the most long-lasting benefit. People have a course of this treatment. They have it daily, 5 days a week for about 4 weeks. And then hopefully that will get them better. Sometimes they have to come back for a repeat course. And sometimes people have to have 2, maybe 3 courses of TMS a year. But as I say, it tends to be well tolerated. There are a few side effects. So it is something that people are happy to have done. And it can be very effective for people who've not responded to medication or who have not tolerated medication. They've had a lot of side effects with medication. So that's one form of neurostimulation, a new form of neurostimulation. There's quite a number. But the other form that I want to just mention just now is one called vagus nerve stimulation. Now, this one's a bit different. And this is one that we reserve for patients who've really got very severe depression that has not responded to a lot of different treatments, because this one requires an operation. This one requires the implantation of a device about so big that is like a heart pacemaker. And we implant that underneath the skin in the chest wall on the left-hand side. And we put a wire underneath the skin up to the vagus nerve, which is in the neck. And the electrodes are wrapped around the wire. And the stimulator stimulates the vagus nerve for 30 seconds every 5 minutes, 24 hours a day, 7 days a week. This device has been shown to be effective in treating epilepsy. And it is something that is reserved for patients who have what's referred to as treatment-resistant epilepsy, epilepsy that's not responded to standard anti-epileptic medication. But interestingly, many of the patients with epilepsy also have depression, and many of their depression, or many of those with depression, their depression got better. Even in patients whose epilepsy didn't improve, we've seen improvements in people's quality of life. Overall, they just feel better. They feel like, life's more worth living. It's better in a very hard to define way. But on the basis of those observations, studies have been done looking at the effects of vagus nerve stimulation, or VNS, in patients with severe, difficult to treat depression. The data is still early in its development. We have got 2 big studies going on, one in America, one in Europe that I'm involved with, looking about whether this works and how well it works and which patients would best be treated with it. But what we've got so far is we've got a study that followed patients up over 5 years. It followed patients up, 500 patients who had treatment as usual from psychiatrists with antidepressants, psychotherapies, all the other things that we do to help people, treatment as usual, TAU. And they had 500 patients with TAU who also had VNS, and we had 350 patients who just had treatment as usual. It wasn't a perfect study because it wasn't randomized to these 2 treatments, but the patients were very similar at baseline. And if we followed them up over 5 years, what we see is that gradually people do improve. The people who had treatment as usual, after 5 years, about 40% had got better. They'd had a response, which sort of illustrates how awful depression can be, because that means 60% hadn't improved even 5 years later, despite having ongoing treatment. But the group who had VNS as well, nearly 70% of them had a response. So much greater numbers of many more people responding when they had vagus nerve stimulation as well as treatment as usual. But the interesting thing is this is the complete opposite of ketamine that works really quickly. VNS works really slowly. It can take 6 months before somebody even notices whether there's any effect of the VNS at all. Even a year, 2 years later, you're seeing more people gradually gaining benefit. And if you look at that graph, you can see that graph gradually increasing over the course of 5 years. A very slowly acting treatment. But interestingly, when people respond, they tend to stay well. So this seems to be a good treatment to actually help keep people well. And what we're interested in doing is using this as a treatment in patients who've had ketamine, esketamine, ECT, possibly even TMS, as a way that they could have the VNS surgery, have this implanted, and then they have the other treatments to get them better just now, while the VNS is gradually working in the background, so that when we stop the ECT, the TMS, the esketamine, they remain well because of the actions of the VNS. Now, we don't know that we can do that for certain, but that's one of the things that we are researching. But there are two other observations which I think are absolutely dramatic with regard to VNS. And they're shown on this slide. So let's just concentrate on the graph on the left-hand side, first of all. It's a slightly complicated graph, but the message is fairly simple. This is looking at those two groups of people shown in the previous slide, those who had treatment as usual and those who had treatment as usual plus VNS. And what it's looking at is reductions in depression on the x-axis, the horizontal axis, and the further to the left you are, the more improvement in depression you've had. And on the y-axis, it's looking at quality of life, how well you're getting on in your relationships at school, at work, general day-to-day life. And the higher you are here, the better your quality of life. So the more we improve depression, the more people's quality of life improves. We know that. That's obvious. It's common sense, really, isn't it? But there is difference between the group who had treatment as usual, the red line, and the group who had VNS, as well as treatment as usual, the blue line. The people who had VNS had a bigger improvement in quality of life for any given improvement in mood. Okay, so however much they improved with their regard to the mood, because some improved only a small amount, some improved a lot, they had a bigger improvement in quality of life than they would have had if they'd had the same improvement in mood just with treatment as usual, conventional antidepressants. Gosh, how on earth could that happen? The answer is we don't know. We still are exploring why and how it does this. But we believe it is a real finding because we see this in the patients with epilepsy as well. VNS has also been tried as a treatment for heart failure. And interestingly, in heart failure, it also seems to improve quality of life, independent of any effect on the actual heart failure. That brings me neatly onto the right-hand side of this graph, because this is looking at mortality, deaths that occurred in the 5-year follow-up of the patients in the study. In the middle, in bold, actually look at the bottom line. The bottom line in bold, this is looking at the rates of suicide. Now, suicide is a tragic outcome for patients with depression. Unfortunately, it doesn't happen too often. It didn't happen too often in this particular study. So this is looking at suicides per 1,000 patient years. And there were 2.2 deaths per 1,000 patient years in the treatment as usual group, but only half that in the VNS group. Now, you might expect that because maybe it improved depression, but it's still more than we might expect for the amount of improvement in depression. But if you look in the middle line, again, let the numbers in bold, this is looking at all cause mortality, deaths from any cause. And in this case, it was mainly deaths from heart attacks and heart disease. In the treatment as usual group, there was a death rate of 8.6. Now, remember, I've already told you that depression increases your risk of having heart disease and it increases your risk of dying from it. But if people had VNS, it was significantly lower. Now, the numbers of patients in these studies is small, and we've got to confirm this. But this is one of the most exciting findings I've seen in psychiatry in the last 30 years, because it suggests we may be able to do something to reverse that increased risk of mortality. So my conclusions: depression is a real and serious illness. It's associated with lots of suffering, morbidity, and mortality. We are increasing our understanding of the biology. There are controversies around treatments, but there are also some exciting new developments which may help improve people's quality of life and reduce the excess mortality. And the key challenge over the next decade, the sort of time that you guys might be coming into medicine, is to help identify which treatment we should give to which patient and when. And finally, 2 websites at the bottom. One, if you want to find out more about what we're doing in terms of research in Newcastle, mood-disorders.co.uk. And the other, a site for self-help or helping others with their mental health issues. So if any of the things I've mentioned today have led to any concern or worry that you might have for you or any of your loved ones, I would highly recommend looking at our Northern Mental Health, all one word, northernmentalhealth.org website. So I'm going to end the slide presentation there and take any of the questions that you've come up with.
Fantastic. Thank you very much, Hamish. That was such an interesting topic. And we've received nearly 170 questions. So we're not going to get through all of those. So what I'll do is I'll just rattle some questions off for you and let you get through as many as you can in the last 10 minutes or so. Okay.
Quick answers then.
Yeah, the first one, I don't know whether you will be able to answer this that quickly, but why does depression increase the risk of mortality from cancer and COPD?
Yeah, okay, so there are lots of different theories, and it's probably for lots of different reasons. If you have depression, you take less exercise. If you take less exercise, you tend to be less healthy. If you have mental illnesses generally, people tend to smoke a bit more, they may drink more, and that may increase your mortality. But also I mentioned that depression increases your stress hormone, cortisol. If you have high levels of cortisol, that leads to increased body fat around your heart, and that can increase your risk of heart attacks. If you have increased inflammatory markers, which we know occur in depression, again, that can increase your risk of various different conditions like diabetes, heart disease. So there are biological and behavioral reasons why that might happen.
Excellent, thank you very much. And would you say that as a result of the pandemic with COVID, that there's been an increased rate of cases of depression?
Yes. Yes, we've seen a big increase in rates of depression. How long that will last for, we don't know. But if you do a cross-sectional survey, you see big increased rates. Whether we'll see that translating into big rates in 5 years' time, 10 years' time, we don't know.
Thank you. And does depression damage the brain?
It can do, yes. There is some evidence that the longer you've had untreated depression, the smaller a bit of your brain, the hippocampus, can become. The hippocampus is important with regard to memory, but also other functions like being able to concentrate on things and also control of emotions and control of your response to stress. So yeah, it probably can damage your brain, which is yet another reason why we need to treat it as quickly as possible and as effectively as possible.
Thank you. And there's been a few questions coming through about how you actually got to the speciality that you now taken on.
How did I end up becoming a psychiatrist when I thought I'd never become one? Well, when I had my initial lectures, we had a slightly different structure to courses in those days, medical courses in those days. So I had some lectures in psychiatry, and I thought, this is a load of wishy-washy, psychobabbly waffle. What a load of rubbish. And I then ended up in a clinical attachment, a clinical placement on a ward with one of the most eminent psychiatrists there was in the country at the time. And he completely convinced me that you could practice psychiatry in a very rigorous, scientific, medical way and get good outcomes for your patients. And he inspired me to look more into psychiatry. I was interested in neuroscience, so I was interested in the brain and the nervous system. So I was thinking I might become a neurologist, but having been inspired by him as a psychiatrist, I thought this has got to be psychiatry. And then when I sat in psychiatry clinics and saw that all the patients were all unique and fascinating, and in neurology, I saw lots of people with headaches and funny turns that you couldn't really work out what on earth was going on. And actually, it's probably more a mental health problem underlying it. I thought, I've got to be a psychiatrist. So after I'd done my initial medical training as an undergraduate, you then do 2 years of training as a foundation year doctor before you're fully registered. And I then took a sidetrack. I went and did a PhD for 4 years in neuroscience. And then I came back and did the standard training in psychiatry, which is essentially 6 years of training after you're fully registered.
Fantastic. I think you've given people the reality of the amount of learning that it takes to
it's a lot of years.
Yeah, definitely. That's something that we often tell people in the role that we're in. Another question, are certain people more likely to develop depression than others?
Well, the simple answer to that would be yes, because we know that genetically, or genes play a part in this, and we know heritability plays a part. So if you have a first degree relative who has had depression, then I'm afraid your risk of getting depressed is slightly raised. It's not a big increase, but it is raised. So even just from that simple point, we could say some people are more at risk. But I think behind the question, it might be, are there certain personality traits or whatever that make people more likely to get depressed? Again, the answer is, well, probably yes, but it's fairly subtle. And we don't see, we would certainly be arguing the case that depression can occur for anybody. Think of Lewis Walpole, an incredibly eminent and successful man who had very severe depression. Okay, so this isn't something that just occurs in weak-willed people. All right, that's the most important message. But there are some personality traits that may put you at increased risk, and there are certainly some genetic traits that can put people at risk. There may be other biological factors. There probably are other biological factors that do put some people at risk. But at the end of the day, it is always an interaction between environment and your underlying biology. Okay, so anybody can become depressed. It's just that some people might be able to get depressed a bit more easily with slightly less environmental insult or challenge.
And leading on from that, can a person with severe depression make a full recovery, in your opinion?
Okay, right. They can get fully well, but I don't think you're always at risk. If you've had an episode of depression, you're at an increased risk of getting depressed again. So what I would say is, if you get depression, if you've got a depressive illness, a severe depressive illness, then you've got that for the rest of your life. But it doesn't mean to say you're depressed for the rest of your life. Indeed, my job is to try and ensure that you are depressed as little time as possible over the rest of your life. And you can still have a life where you are no longer depressed. Lewis Walpole had severe depression, yet he still was a successful academic anatomist. He got the next best award to a Nobel Prize. He became a Fellow of the Royal Society of Medicine, a Fellow of the Royal Society. So, you can be incredibly successful even if you have a severe mental illness, because there are things we can do to keep them under control.
Excellent, thank you. And I think this relates to one of your earlier slides. It's a question asking, how early is early life stress?
We don't know. In a lot of the animal studies that have been done to explore it, it was adversity in rats, days 1 to 5 of life. Now, I think in humans, the vulnerable period, and I think we think of vulnerable periods, is probably a lot longer than in a rat. It probably spans a few years, and it probably doesn't necessarily end, but it just becomes less of an issue. But it probably occurs, I don't know, from year 1 through to years 6, 7, 8, and then the risk may just get a bit less. But it doesn't mean to say that if you have adversity age 10, 12, that you're not going to suffer the problems and consequences of that. But there again, if you suffer severe adversity as an adult, if you suffer trauma as an adult, that increases your risk of becoming depressed as well.
Thank you. And a few questions came through asking, how do you tell that it's depression rather than just having a down few weeks or feeling a bit low?
Okay, so that is where clinical acumen comes in. I can't do a blood test, I can't do a scan. I have to talk with my patients and understand what they're thinking and feeling and how they are acting and behaving. And what I'm looking for is evidence that they've got multiple symptoms, not just 1 or 2, that they've got at least 5 symptoms of a depressive illness. So that's the low mood, lack of interest and pleasure, poor sleep, poor appetite, poor concentration, thoughts of death, suicide, feeling guilty. I'm looking for multiple symptoms in amongst that group occurring for a prolonged period of time, at least 2 weeks, and it's usually over a month or 2 minimum, that is impacting on that person's functioning in their normal daily life. So that's what I'm trying to make an assessment clinically of. And that's how I differentiate it from normal human sadness.
And I think we'll make this the last question of the night. Just asking what your kind of favourite aspects are of your career and why you chose to end up where you are.
Well, I would say 2 things. One is all patients are totally different. So patients are endlessly fascinating. And I like talking with people. I like finding out, how they're getting on. And I like to see them getting better. We have effective treatments. And it is so rewarding seeing them get better and talking through how they're getting on and learning how their lives are getting back to normal again. That is just so rewarding. But on top of that, the second thing would be my fascination in neuroscience and understanding how the brain works, what underlies depression, and learning more about effective treatments. In the latter part of my career, I've been working on treatments and developing new treatments and studying new treatments in the hope that these are things that I can then take from research through into the clinic and the patients that I'm actually dealing with. And being able to do that, being able to do research on a treatment and then go, gosh, this works. And then taking it into the clinic and giving it to a patient and they get better. And you just go, right, this is all just worthwhile. This is what I got into this for.
Thank you. I think that's a really positive place to end it. So thank you very much, Hamish, for such a fascinating talk and for giving up some of your evening. And thank you to everyone who's attended tonight as well. Thank you.
Thank you. Thank you.
Good night.
Bye.